So let's talk about the focus history. To be able to take a focus history, you need to think about what are the steps you need to take, because taking a focus history is not going to happen just by hoping that your history is focused. This is skills that you have to develop to be able to get to that level where you're taking a focus history. So common pitfalls I see is registrars not being inquisitive enough. The history is disorganized. The questions that they ask is not really selective. It's very poor use of question. And there's a lot of question that's just going in circle, clarifying, and not really progressing. So it's not really focused. It's just very vague, and there's not really good history in that. And then there's excessive use of summary. Other things that happen is that registrars might go and do things where they're opening new windows. For example, they're asking questions about other medications that's not relevant. Then the patient bring up other things, and there's multiple problems in the consultation. So these are common pitfalls you want to avoid to take a focus history. So when you're taking a focus history, I'd like to use this analogy where, let's say you're going on a treasure hunt. It's on a vast field and you're looking for that treasure. What are the things that you need to get to this treasure? What are the tools that you need?
A map.
Yeah, you need a map, because without a map, you're going to get lost. That's very good, Osama. Anything else?
A shovel.
You need really to be equipped. Otherwise, you're just going to waste your time and energy. So if you've got a shovel, but you haven't got a map, what you're doing, you're going to dig in the wrong place. And it's going to take you a lot of effort and time where you're not going to get the results you want. But if you've got a map, you know exactly where you need to dig, because you know where this treasure is. So that's why you need to be organized. So when you've got a map and you've got your shovel, then you can start digging where you have a higher chance of getting to the treasure. So the map is really like the structure that you've got. When you've got a structure, you know exactly at 2 minutes where you're at, 4 minutes where you're at, 6 minutes where you're at, so that you're going on track. And then the shovel is the questions that you're asking. Each time you're digging, you're asking a question to get more information, and that will lead you to the treasure. That's why it's so important to spend some time in the pre-consult before you even consult your patient. You need to do that prep, because if you don't do that, then you're just going blindly. So what you do, you scan the patient's record. That's really important to look at the record to see whether there's anything relevant. You prime your case beforehand, and you anticipate the consultation. So by that, I mean that what you need to do, you play the consultation out in your mind. If you're playing it out in your mind, you're thinking about the consultation and how it's going, then you're organizing your thoughts and you're considering the potential diagnosis. And if you find that there are things that you're finding when you're doing that exercise and you think you might forget it, just jot it down. Jot down on a fresh piece of paper what you plan to cover. Because when you do that, then it's less likely that you're going to forget things. Because sometimes I see people, they forget a lot of things and they have not really planned this out in their mind. If you're struggling with the RCA and you believe that you need help, then I'd recommend that you click the link down in the description below to book a free call to see whether we can work together on a one-on-one coaching program. If I think that I can help you, then we can get you on the coaching program. But if I can't help you, then at least you'll get some insights. So these are the 6 maternal case selection criteria. For maternal reproductive health, you need to be very focused on what sort of cases you're going at. Registrars who are going for very complex cases and they're struggling to get cases like menopause and HRT, you need to look at how long have you got before submission and whether you can afford to spend so much time getting these cases. So for example, there are cases that are more attainable if, let's say, you're sitting in January and you haven't got one yet. So cases like nausea and vomiting in pregnancy, cases like if somebody is presenting with pelvic pain, that might be more suitable than going for a case like HRT, which is feasible. You can still get one, but you might find that it's going to take you maybe 5-10 recordings before you can get a good one that's suitable. Because the problem with cases like HRT is that you have to cover a lot of things within 12 minutes. So it's very, very complex. Think about how long have you got and which cases are common in your practice and which cases you can get a good recording. So in this minor case selection criteria, there has been changes. So I would avoid any breast lump cases because it's just not very good. You can submit cases like fertility. For example, if patient presents with history of diabetes, that might be a good case because there might be other things to consider. The next one is long-term condition. For long-term condition, there is a very wide range of cases you could capture. But what you want is a case that has got an angle to it. You need to think about the RCA as if you're organizing an OSCE and what station you're going to put in that OSCE. So if you're going to arrange an OSCE, you want a case to test something from that candidate. So you don't want to just put a case there that's just a long-term condition. For example, a good long-term condition would be a patient presenting with shortness of breath, has got a background history of COPD that's already been established, and now they're developing copulmonale, and you're thinking about heart failure. That would be a really good complication to cover. So it needs to be already established. You can't have a new diagnosis of a long-term condition. The next would be an older case, so over 65 years old. So that's quite common. I think most registrars, they get these cases quite well. There shouldn't be any issues. So it could be something like memory loss. It could be depression. It could be patient presenting with some problems like abdominal pain, but anything, as long as a patient is over 65, that should be all right. Then there is a case involving a child who is 16 years or younger. I recommend that you get a face-to-face appointment for that one, because face-to-face is better to cover child, because you interact with the child and you can see the child, which is much more focused in terms of your assessment rather than doing a telephone assessment. And usually over telephone, you will get the parent, so it's not even talking to the patient. So that's why I recommend to do a face-to-face if you can. The next one is mental health condition. So mental health, there's various mental health cases. So you could look at anxiety, insomnia, depression. Make sure that you've got a case at complexity level that's manageable within 12 minutes, because some of the complexity where you have the suicidal ideas, you have to look at various things, then it might not be a suitable case. The next case is acute problem. So acute problem, it's any case where you're requiring to make an urgent referral. That includes a 2-week wait, an admission, or an urgent referral outpatient. Or if you're having to request an urgent investigation, that would fulfill the criteria.
Can I say something about this session? I'm really glad that I got on it. I'm really happy because there are quite a lot of things that you have mentioned. I mean, the way you just talked about personalizing management, I've never thought of it that way before. And I've never heard it taught that way as well. I just used to think it was more of just give options and just listen to what the patient says. But actually thinking about the options you're giving and how it fits into the patient's presentation is actually what makes it really personalized, not just a generic thing that you offer anybody who comes with that symptom. It's actually painted. I mean, yeah. So, and I'm really glad that you've really, really highlighted the fact that I really need to do more of exploring differential diagnosis. I'm not doing enough. So it's something I have to work on, definitely. So I have to open up my differentials better. I'm really glad. I'm really happy. This is, I mean, I've attended about two other RCA. One was from the deanery. The other one, I just thought I should just get on it and just listen. And I've not felt this way. So this is really good. and I can't wait to get back to start recording again.
That's great. I'm glad that it's now clicking in your mind, because once you understand the reason we're doing it, it changes everything, because your perspective and the way that you do it completely changes. If you're struggling with the RCA and you believe that you need help, then I'd recommend that you click the link down in the description below to book a free call to see whether we can work together on a one-on-one coaching program. If I think that I can help you, then we can get you on the coaching program. But if I can't help you, then at least you'll get some insights. I hope you find this video useful. Let me know down in the comment section if you have any questions or any suggestion. Take care, everybody. Bye-bye.